What I'd like to look at right now on page 287, is to introduce you to how we evaluate pulmonary ventilation, how we evaluate how much air one inhales and how much air one exhales. And these are commonly known as pulmonary function tests. And the device that's classically used to measure how much air is being inhaled in or exhaled out, the device that's commonly used is called a spirometer. And that's why the use of a spirometer to measure these lung volumes is known as spirometry. So the spirometers are used to measure the volume of air that's inhaled or exhaled. The classic device is pictured right here on page 287. And classically, there was a tank filled with air and connected to a tube, and an individual would be asked to inhale or exhale. As they drew air from the tank into their lungs, the volume of air in the tank would decrease, and as they exhaled air and blew it out of their lungs, out of their mouth, into the tank, the volume of air in the tank would increase. There was a pen attached to this graph paper, and as the volume of air in the tank increased or decreased, that would cause a change in this line, and it would create these waves, as it were, indicating either an increase of air in the tank as one exhaled or a decrease in air as somebody inhaled. These lung volumes, these volumes that are measured, are used to diagnose different types of lung or pulmonary disorders. These lung volumes are affected by three major things. They are affected by the person's age, by how big their size, how big they are, and by their gender. So, not surprisingly, the lung volumes of a child are different than that of an adult, and they would be different in an elderly person. A person who is small or petite would have a smaller lung volume and smaller volumes of air they're inhaling or exhaling compared to a very large person. And as far as sex or gender, not surprisingly, males have a larger lung volume, lung capacity, than the average female does. So let's go through some of these more common lung volumes. Now the first one that we've listed, we've described already, it's called tidal volume. And it's commonly abbreviated either TV for tidal volume or V sub T, volume tidal. What is the tidal volume? That's the amount of air one inhales with a single breath and then exhales. And the reason why it got the name tidal volume is it was somewhat poetic. Just as at the ocean, the tide comes in and the tide goes out, similarly the air flows in and the air flows out when you take a breath. Normally at rest, a normal person would inhale about 500 milliliters of air with each breath. They'd inhale 500 milliliters of air, which is a half a liter of air, and then exhale that same amount. Now, a very important term is the functional residual capacity, or FRC. That's the amount of air that normally is still remaining in our lungs after we have exhaled. In other words, we take a breath in, and we exhale it out, and there is still a significant amount of air remaining in our lungs called the functional residual capacity. It's called residual because functionally that's how much air is still residing or still located, residual, residing in our lungs even after a quiet exhalation. On the next page, 288, so on the top of 288 it just shows a recording from a spirometer. Incidentally, I mentioned that classically you would blow into this tube and it would increase the amount of air in the tank and decrease the amount of air in the tank. The more modern spirometers don't even require a tank filled with air. There is a tube a mouthpiece one sticks into your mouth. There is an electronic sensor that is connected to a computer, and literally as somebody is inhaling, it measures the volume of air that one is inhaling by this electronic sensor. As one exhales, it measures the amount of air one exhales. So this is all done electronically nowadays. But in this classic recording, it's showing how air in the tidal volume is going in and out and in and out. And here it's, we're going to get into this, taking a big deep breath and taking exhaling. And so this is classically how we depict these changes in lung volume as one inhales or exhales varying amounts of air. And right below that, what is the expiratory reserve volume, or ERV? That's the amount of air that you can exhale above and beyond what you normally exhale after a quiet breath. In other words, normally we inhale and then exhale, but we could exhale even more air if we chose to. I could inhale, exhale, and exhale even more. Sorry about that, a little disgusting. That additional amount of air that we are able to exhale above and beyond what we normally exhale is called our expiratory reserve volume. The residual volume, or RV, is the amount of air remaining in our lungs no matter how hard we exhale. If we exhale as hard as we possibly can, there will still remain some air. There will still be a volume of air still remaining in our lungs. It's about 1 liter that we cannot exhale out. That's called the residual volume that is always remaining in our lungs. The only way that that air would be come out of our lungs is if our lungs collapsed, and we don't want that to happen. The inspiratory reserve volume, the IRV, is the volume of air that we can inhale above and beyond our normal tidal volume. So in other words, normally I take a tidal volume, I inhale a ½ liter of air, but I could inhale even more. Okay, that additional amount of air above and beyond my normal tidal volume is called my inspiratory reserve volume. Now, all of these terms can actually be viewed, I think, best. I think the easiest way to understand them is in this picture right here. And you can think of the amount of air in your, the amount of air that is in your lungs at any moment in time, you can think of it similar to a balloon. Obviously, you can inflate a balloon, you can deflate a balloon. You can add air to the balloon, you can let air out. So, what this is showing, if you look at this right here, this says RV, residual volume. That's that term right here. Residual volume. ERV, expiratory reserve volume. That's here. Then it says TV, that's the tidal volume on the previous page, and the IRV, the inspiratory reserve volume. Now, normally the amount of air that is remaining in our lungs after a normal quiet exhalation is called the functional residual capacity. And that's this amount of air right here. This volume, your lungs would be this full if represented like a balloon. This was how much air is still in your lungs after a quiet exhalation. And I made that blue just to draw attention to it. That's called the functional residual capacity. Now, then you take a normal breath in. That breath of air, that 500 milliliters of air that you inhale is called your tidal volume. And that expands your balloon, your lungs, to here. So you've added this much air. And then you exhale it. So then you exhale 500 milliliters of air, and you are back to this blue line, the functional residual capacity. So literally, as you are inhaling and exhaling, you are simply inflating your lungs. They're going from here to here, and then deflating them right back. So again, just inflating like this to here, and then deflating back. Now, let's imagine you took a normal breath in, and then you added even more air. So what would it look like? You would take your normal breath in, it would be this full, and now then inhale even more air, as much as you possibly can. What you've added is the inspiratory reserve volume. So in other words, you took a breath in, and you even took more air. You filled your lungs up as much as you could. What you've now added is the inspiratory reserve volume. Okay, let's return back here. This is how much air is in your lungs after a quiet exhalation, called the functional residual capacity, an important term. Normally you inflate your lungs, you add a tidal volume, and then you deflate it, you exhale it back to here. Let's try exhaling even more air. In other words, we're going to inhale, exhale, and now exhale as much as you possibly can. What you've just done is to get rid of the expiratory reserve volume, so that all that is still remaining in your lungs is the residual volume, which you cannot get rid of. So when you exhale as hard as you can, there is still this residual volume of air remaining in your lungs, no matter how hard you exhale. Okay, so let's return back again. Normally, we don't exhale all the way, so let's fill our lungs, and we've got this much air in our lungs. That's called the functional residual capacity. Let's take a breath in. Let's exhale. Let's take a breath in. Let's take a really additional deep breath of air, as much as we can. Fill up our lungs all the way. Add that inspiratory reserve volume. And now we've inflated our lungs to their maximal capacity. That's called your TLC. That does not stand for tender loving care. It stands for total lung capacity, which is right here. That's the total volume of air in your lungs after a maximal inhalation. Okay, now we're getting into the important part as far as measuring lung volumes and evaluating pulmonary function. One of the very important things they measure is something called the FVC, the forced vital capacity, FVC. The forced vital capacity is measured by inflating your lungs all the way, as much as possible, to their total lung capacity, and exhaling as much of the air as you possibly can. What you are exhaling is everything down to the residual volume. So you inflate your lungs all the way. You can try this as I describe it. And exhale. All right, so you're exhaling your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume. All that is still remaining in your lungs after you exhale as much as you possibly can of that air is the residual volume. That's all that's left. This volume of air that you exhaled is called the forced vital capacity, the FVC. And what it actually is the total lung capacity minus the residual volume. So it's really, this is the forced vital capacity. It's equal to the total lung capacity minus the residual volume. Now, if anybody has ever done these pulmonary function tests, and if you ever have to, here's what they tell you to do. They're going to tell you to inflate your lungs as much as you can. They're going to tell you to exhale all the air you possibly can. And they'll say, keep going, keep going, keep going. And you're trying to exhale it all. But what they're actually also telling you is when you do exhale, you should be exhaling that, not only all the air, but you should be exhaling it as hard and as fast as you possibly can. Now, if we take a look at page 291. On page 291, so on 291 in the middle of the page, forced vital capacity is the largest volume of air that can be forcefully exhaled after a maximal inhalation. It's the total lung capacity minus the residual volume. The last term we want to give you is called the forced expiratory volume in 1 second, or sometimes called the timed vital capacity. It's the only one of these terms, of all these terms we've given you, that has a number. FEV1. This is the volume of air that you can forcefully exhale in the first second. So they will not only measure the total amount of air you exhale, they will measure of that how much of that air you were able to exhale in the first second. And we wrote here that a normal person, a normal young adult, should be able to expel or exhale 80% of that forced vital capacity in the first second. Do you think that somebody who has a respiratory disorder, a pulmonary disease, such as bronchoasthma, emphysema, tuberculosis, bronchitis, and so on, do you think that person would be able to inflate their lungs and rapidly and forcefully exhale the normal amount of air in a very short amount of time compared to a normal person? In other words, do you think somebody with a pulmonary disease can exhale the normal amount of air that a normal healthy person could in the first second? And the answer is obviously not, because they have problems in moving air rapidly in or out of their lungs because of obstruction or of their lung function. So, in fact, we wrote that this percent is decreased in obstructive airway diseases such as pulmonary edema, fluid in the lungs, myasthenia gravis, and a woman who's pregnant cannot move air as rapidly in or out of their lungs as a normal person who's not pregnant is able to do. Let's show you an example of what we mean by taking a look at page 290. So on page 290, so this is a pulmonary function report from Cedars-Sinai Hospital, the information is about the patient is given at the top. Now the information we're told is this patient is a male, John Canning. He was 72 years of age. He was 66 inches tall, that's 5 foot 6 inches tall, weighed 173 pounds. Remember, we've said that these lung volumes are affected by one's age, they are affected by one's gender, and by one's size. Now, they measured all these different aspects of lung function. Some of these we've mentioned, and in addition, they measured a whole bunch of other stuff as well. The two things that I want to draw your attention to are where they measured the forced vital capacity. That's the volume of air that a person can maximally exhale. Remember, you inflate your lungs all the way, and you exhale as much of the air as you possibly can. And for this individual who's 72 years of age, they predicted that he should be able to exhale a volume of 3.46 liters of air. Now, when they actually measured this patient, he was only able to exhale 1.9 liters of air, not the normal 3.46. So he only was able to exhale 54% of what they predicted he should be able to exhale. Now, they also looked at, of that volume of air that he exhaled, what percent was he able to exhale in the first second? Now, for an individual of his age, they predicted that he being an older person, it should normally only be able to exhale 72% of the forced vital capacity in the first second. A normal, healthy young adult should be able to exhale 80% of their forced vital capacity. They predicted he should have been able to exhale 72%. When they actually measured it, he was only able to exhale 31%. So that's less than half of the percent of air they predicted he should be able to exhale in the first second. Now, these were the measurements they determined before the use of a bronchodilator. They then administered a drug that dilates the airways to presumably make it easier for the air to flow in and out of the lungs. And they remeasured the forced vital capacity. And now the forced vital capacity, after the use of a bronchodilator, became 2.3 liters of air. Originally it was 1.9. So that was a 21% improvement, a 21% improvement in the volume of air he was able to exhale. When they looked at the percent that he was able to exhale in the first second, it improved from 31% to 39%. That's not a very big percent improvement as far as how rapidly, how much air he could exhale in the first second. If we look at the summary of this patient, the interpretation, so in the interpretation, the pulmonologist who was involved in evaluating these tests interpreted that there is a very severe obstructive defect and obstruction of the airways, improvement in the vital capacity or forced vital capacity, and the forced expiratory flow rates, in other words, the FEV1, following isoethérine inhalation, and isoethérine is the name of a bronchodilator, suggests that this patient would benefit from the continued use of bronchodilator therapy. So these are the measurements, the kind of measurements they make in evaluating lung function, pulmonary ventilation, and the ability to move air in and out of the lungs. You'll notice that on the next, on page 289, you'll notice that on page 289, here's a similar pulmonary function report from St. John's Hospital in Santa Monica. And again, you can see all these terms, some of which we've given you, some of them we have not. Here you can see forced vital capacity, or FVC. Again, that's the volume of air that one can forcefully exhale. And then the forced expiratory volume in 1 second, that's the FEV1. And the percent of the FEV1 over the forced vital capacity, which normally should be about 80%. And over here on the right, they can measure total lung capacity and the inspiratory reserve volume and the expiratory reserve volume, and the functional residual capacity and the residual volume, and so on. So that's how they can evaluate pulmonary function. If we look on page 293, on page 293, quantifying pulmonary ventilation. So here what we want to present to you on page 293 is how we determine the amount of air one inhales each minute. This is known as the minute ventilation. The minute ventilation. Now, minute ventilation is designated by a V representing volume, and the dot placed above the V means per minute. So minute ventilation is the volume of air inhaled per minute, volume per minute. So now, of course, the amount that you exhale each minute should normally be equal to the amount you inhale each minute. So those should be identical. Now, the formula for determining the amount of air that is inhaled each minute is equal to the frequency, how many times a minute one is breathing, taking a breath, multiplied times the tidal volume, the volume of air inhaled with each breath. Now, when we look at this formula for determining the amount of air we inhale each minute, what formula does that remind you of? Well, what it reminds me of is the formula for cardiac output. Because we had learned that we can determine the amount of blood pumped by your heart each minute is determined by how many times your heart beats each minute, heart rate, multiplied times the stroke volume, which is the volume of blood ejected with each beat. So I see a very nice parallel between determining the amount of blood pumped or ejected each minute and the amount of air inhaled each minute. Now, the numbers that I've used here is I've suggested that we normally breathe about 15 breaths per minute at rest. Most of the books will say about 12 breaths per minute at rest, but whenever any nurse or clinician starts to measure how many breaths a patient is taking each minute, the patient becomes self-conscious and will automatically start to breathe faster. So I think this is closer to what you would actually see if you tried to measure the number of breaths somebody was taking each minute and they were aware that you were watching them. Of course, the normal tidal volume, the amount of air inhaled with each breath, is about 500 milliliters of air with each breath, or half a liter. If we, you'll notice that if we multiply these two, the breaths cancel out, and the answer is going to be in milliliters per minute. 15 times 500 is 7,500 milliliters of air are inhaled each minute, which is equivalent to 7.5 liters of air per minute. Now, if an individual is breathing significantly less than 7.5 liters of air each minute, we would say they are hypoventilating. They are breathing less than what they should. If somebody is breathing significantly more than 7.5 liters of air per minute, they are hyperventilating. Now, of course, we would all be hyperventilating when we're exercising, but we're talking about at rest. And at rest, somebody should not be breathing significantly more than about 7.5 liters of air per minute at rest. If they are, that would be hyperventilating. Now, the next thing I want to address is that every time we inhale air, the only air that actually benefits us is the air that goes all the way down deep into the alveoli, or air sacs, of our lungs. In other words, when we take a breath of air, the air that's up in our throat has not benefited us because it is located in what's called the dead space, the conducting division of the respiratory system, or the dead space. You might say, well, what do you mean? So, dead space. What is the dead space? That's the volume of air that doesn't actually reach, our alveoli every time you take a breath. So when you take a breath, whether you breathe through your nose or your mouth, it goes down your throat, it goes down through the larynx, the trachea, the bronchi, the bronchioles, and all the way down to the alveoli. When you take a breath of air, we typically breathe 500 milliliters of air at rest with each breath. The last 150 milliliters of air we inhale are up in our throat, in our larynx, our trachea, our bronchi, and our bronchioles. That air doesn't help us in the sense that the oxygen in that air does not enter the bloodstream. The only location where oxygen can enter the bloodstream is down at the microscopic alveoli, or air sacs. That is the only location where oxygen goes out of the lungs at the alveoli and enters the bloodstream, the pulmonary capillaries, and at the same time carbon dioxide diffuses or flows out of the bloodstream and enters the alveoli of the lungs. There is no exchange of oxygen with the bloodstream in your throat or your larynx or your trachea or your bronchi or your bronchioles. So, on the next page on 294, so we said that the dead space, that volume where air is up in your throat and your trachea and bronchi, is about 150 milliliters. So, with each inhalation that you take, the last 150 milliliters that you inhale are up in your throat. In other words, as I take a breath of air, I'm going to inhale it. Okay, so the first air that I inhaled went all the way down to my alveoli, but the very last part of my breath is up here in my throat. So that's in the dead space. So, if we would like to determine, as we're breathing, how much air actually made it down to our alveoli, That determination is called the alveolar minute ventilation. It is designated with a V, which designates or specifies volume of air. The subscript letter, capital letter A, stands for alveoli, so the volume of air in the alveoli, and the dot above the V means per minute. So literally, the volume of air in the alveoli each minute, the alveolar minute ventilation. That's the functional amount of air that actually went down into our alveoli each minute. We can calculate that using this formula. So, in this case, we're going to first subtract of the tidal volume, the 500 milliliters of air that we breathe with each breath, we're going to subtract out the dead space, which is normally 150 milliliters of air with each breath. In other words, 500 milliliters you may have inhaled, but the last 150 milliliters of air is up in your throat. So how much air actually made it down to your alveoli? 500 minus 150 is 350 milliliters of air with each breath actually made it down into our alveoli. Now, if we multiply that times the frequency that we're breathing, 15 breaths per minute, we will be able to calculate how much air actually makes it down to our alveoli each minute. So 15 times 350 is 5,250, and the units are, breaths cancel out, milliliters per minute. 5,250 milliliters of air per minute is equal to 5.25 liters of air per minute. So even though we inhaled, on the previous page, we are inhaling 7.5 liters of air into our mouth each minute, normally. Of that, only 5.25 liters of air each minute actually makes it down to our alveoli. So that's the more important number. Now, what I find very interesting is that when we calculate the cardiac output, the normal cardiac output, the amount of blood ejected by each pump per minute, is 75 beats a minute times 70 milliliters of blood ejected with each beat. That's the stroke volume, which comes out to be 5.25 liters of blood is pumped or ejected per minute at rest. So I find it very interesting that the volume of blood ejected by your heart each minute is the similar number to the amount of air that actually is inhaled and makes it down to your alveoli each minute, 5.25 liters per minute. Now, in order to make sure that you understand what we've been talking about, not only knowing how to calculate it, but also the deeper understanding of what this means, so we've given you some problems to try. Imagine we have a patient who can breathe in 3 different ways. He could be breathing 40 breaths per minute, taking in 250 milliliters of air through his mouth with each breath, the tidal volume, with a dead space, the normal dead space of 150 milliliters. So what we've asked you to do is to calculate what is the minute ventilation. The minute ventilation is calculated by multiplying the frequency, how many times a minute the person's breathing, times the tidal volume. And then to calculate the alveolar minute ventilation, that was this term right here, the alveolar minute ventilation, which is calculated by taking the tidal volume, in this case 250 milliliters, subtracting the dead space from it, 150, and then taking that number and multiplying it times the frequency of 40 breaths per minute. If you, in the second case, imagine the same person, the same patient, breathing 20 breaths per minute with a tidal volume of 500 milliliters with each breath, same dead space, and imagine that the same patient breathing just 10 breaths per minute, more slowly, but taking a deeper breath, tidal volume, a deeper breath of 1,000 milliliters with each breath, and again the same dead space. So if you try calculating these, let's see what you get. Calculating the minute ventilation followed by the alveolar minute ventilation. Now, if you've calculated these, let's just first take a look at minute ventilation. Minute ventilation is simply calculating how much air entered your mouth each minute. It is determined by multiplying how many times you're breathing per minute times the tidal volume, the amount of air you inhaled with each breath. So, in this case, all you do is multiply 40 breaths per minute times a tidal volume of 250, and you would get 10,000 milliliters of air are inhaled into your mouth each minute, which is equal to 10 liters of air per minute. If you then calculate the minute ventilation for when somebody is breathing 20 breaths per minute with a tidal volume, a deeper tidal volume, a bigger tidal volume, not 250 but 500 milliliters with each breath, similarly, you will get 10,000 milliliters of air inhaled through the mouth each minute, which is again equal to 10 liters per minute. In the third situation, letter C, somebody who's breathing more slowly, just 10 breaths a minute, but with a bigger tidal volume, 1,000 milliliters of air is inhaled with each breath. 10 times 1,000 is 10,000 milliliters of air is inhaled through their mouth each minute, which again is equal to 10 liters per minute. Now, if we stopped with just that, we would conclude incorrectly that it doesn't matter. You might think incorrectly that it doesn't matter whether you breathe fast with a small tidal volume, not a small breath, or whether you breathe more slowly with a deep breath, a big tidal volume. You get the same amount of air in both cases, in all these three cases. But in fact, it really does make a difference. When we take into account the dead space and calculate the alveolar minute ventilation, these are the numbers that we get. So in this case, calculating the alveolar minute ventilation, this is where we take the person who's breathing 250 milliliters with each breath, we subtract out 150, so that's 100 milliliters of air actually makes it down into their alveoli each minute, multiplied times 40 breaths per minute is 4,000 milliliters of air inhaled through the mouth each minute, or 4 liters per minute. Amazing! Even though 10 liters of air are entering the mouth each minute, only 4 of the 10 liters of air make it down to the alveoli each minute. In the second situation, where the person is breathing 20 breaths per minute, but taking a deeper tidal volume of 500, so we get, again, subtracting out the dead space, 500 milliliters minus 150 is 350 milliliters of air, actually make it down to the alveoli each minute, multiplied times 20 breaths per minute, and you get 7,000 milliliters of air, or 7 liters of air, actually make it down to the alveoli each minute. That's amazing. That's almost twice as much air makes it down to the alveoli, breathing more slowly but a bigger tidal volume than breathing faster with a smaller tidal volume. Now, in the third situation, the person has a tidal volume of 1,000. Let's subtract out the dead space of 150. That's 850 milliliters of air. Make it all the way down to the alveoli with each breath. Multiplied times 10 is 8.5 liters of air. Make it down to the alveoli each minute. If we compare how much air is making it down to the alveoli each minute with the first situation, it's more than twice as much air makes it down to the alveoli each minute by taking these big breaths, these big tidal volumes, rather than these small tidal volumes. Okay, so the first point that we can conclude, in addition to knowing how to do the calculation, is that the bigger the tidal volume, the more air makes it down to the alveoli. But I want to make sure you truly understand why that's the case. I'm going to give you an absurd example to really drive home the whole point of all this and what it really means. What if somebody was breathing 100 breaths per minute, really fast, almost impossibly fast, and they were taking a very small tidal volume of 150 milliliters of air. They're just taking a small breath, 150 milliliters of air with each breath, and they've got a dead space of 150. How much air? And they're breathing 100 breaths a minute. How much air makes it down to their alveoli each minute? Well, in order to calculate the alveolar minute ventilation, we take the tidal volume minus the dead space volume. 150 minus 150 is 0. So they're actually getting 0 amount of milliliters of air reaching their alveoli. And it doesn't matter whether you multiply 0 times 10 or 100 or a billion, it's 0. 0 amount of air is reaching their alveoli each minute. Let's really make sure you understand why this is. If all I do is inhale 150 milliliters of air into my mouth, I've only filled up my throat, my larynx, my trachea, and bronchi with air. Not a single drop of air has made it down to my alveoli. I've simply filled up this space, the conducting division, the dead space. If I inhale not 150 milliliters, but 151 milliliters of air, how much air now makes it down to the alveoli? 151 minus 150, or 1 milliliter of air, makes it down to my alveoli with each breath. What if I inhale 152 milliliters of air with each breath? Then it's 152 minus the dead space of 150, so 2 milliliters of air makes it down to my alveoli. In other words, the bigger my tidal volume, the greater it is above and beyond the dead space, the more air actually makes it down to the alveoli. So taking a large deep breath gets more air down to the alveoli than taking smaller, shallower breaths. So this also has consequences as far as mouth-to-mouth resuscitation and CPR. So on page 286, we had a person who was rescuing a victim. So if you had the option of you're going to go and do CPR, you're going to go and breathe into this person to save their life, so what would be more effective in terms of giving air to them? Would it be more effective for you to take rapid breaths, but shallow breaths? So would it be more effective if you rapidly inhaled small breaths of air into their mouth? Or would it be more effective if you delivered a greater volume of air more slowly? And also, how will that affect how tired you become? In other words, what would be more effective in delivering more air to the victim? Breathing like this, or like this? Obviously, it'll be less tiring to the rescuer to do this more slowly, and more beneficial to the victim to receive large breaths of air and going into their lungs and delivering lots of air down all the way deep in their alveoli, rather than trying to do this rapidly and simply blow small volumes of air into their lungs, which primarily just fills up their throat, their trachea, and their bronchi, and very little air makes it down to the alveoli.